Good afternoon, everybody. Thank you so much for gathering here today. Before I get started, can I just check how many of you are infection control nurses? No. How many of you work with ICNET already? Oh, that's great. So we've got an even spread across the room. Just to introduce myself, my name is Emma Hoyle. I'll just go to the next slide. Oh. There we go. My name's Emma Hoyle. I'm Deputy Chief Nursing Officer from Dorset County Hospital in Dorset, but I'm also the Associate Director for Infection Prevention and Control, and I've been leading on infection control for the last 5 years at Dorset County. I'm also the winner of the prize with the longest title of presentation today. So I'll be sharing with you, learning from experience, the experience of using innovative technology to maximise IPC clinical workflows during the COVID pandemic, and how this is driving best practice for future IPC strategies. So before, during, after and onward with IPC. So just to give you a little bit of information about what I'll be talking about this afternoon, I'd like to give you a bit of background to IPC and the model we use for infection control at Dorset County Hospital using ICNET. I also want to share some real experiences and techniques of how we've used ICNET in a rural district general hospital over the pandemic. And part of that is looking how we identified patients with COVID and optimised ICNET to get the best bed placement for those patients over the last 2.5 years. How we use the mobile tech that we can use our iPads with ICNET to optimise staff use of ICNET, whether they be shielding, working from home, or working on site as well. And also how we use the data analysis functionality of ICNET to give us some evidence base to take up to board to give them performance and give some explanation, evidence on how we were doing. And I'll also explain to you how we're working as a Dorset-wide system with ICNET, understanding that a lot of you are working in boards within Scotland, something which is a new concept to the UK, to England. We're working to something called the integrated care system. So we're now developing all our areas into a very similar system to your boards you're working with in Scotland. So where are we? We're right at the bottom of the country, so as far away as you could possibly get, that's where we are. And I always say, when people say, how big is Dorset? It's the size of Oahu, which is one of the islands in Hawaii. So we always like to think we're a little bit tropical down there. We're one of the only counties in England that doesn't have a motorway going through it. And those of you who know Dorset know it's a very beautiful place to be. But in the summer, it's a very busy place to be. So our summer is our winter. So, and I am based where that little star is in Dorchester, and that serves the west of the community in Dorset. And we are a rural district general hospital. We've got 390 beds. We did have 300 at the beginning of the pandemic, but we've repurposed many areas. I'm sure some of you have done that as well, to provide capacity for the ongoing issues the pandemic has caused. It's not just COVID. We have, at present, I believe, 80 no reason to reside patients in the hospital at the moment, which does cause a flow problem for the hospital. We're the catchment area for the west of Dorset, so we have probably 2 large towns it's covering, so Weymouth and Dorchester, but there's a lot of villages and small towns in the west of Dorset. We are the trauma centre for that area, and those of you recall in 2012 when the Olympics happened, we actually had the sailing events in Dorset, in west of Dorset, so we had the trauma centre status awarded to us then. And we're also the renal centre for the whole of Dorset and South Somerset. So we cover the inpatient renal beds, but also manage the satellite units across the county, serving the patients around the whole area. And we've been digitally live with ICNET since 2013, so nearly 10 years. So how do we use it at Dorset County? We have used this as an integrated programme of how we work. Before we had ICNET, we worked from Excel sheets and self-made work plans and worksheets. And we have created a model that we can use as part of our daily ward rounds. So those of you who know ICNET, we've created an open cases list, which is basically forms our work list as we go around the hospital. And by doing that, the accessibility for the mobile device, we know that functionality is consistent throughout the area, but also off-site as well, so it can be used at home if need be. It's embedded in practice, so it's something which, as we've been using it for such a reasonable length of time, it's part of the normal working of infection control. And it means that we are on the wards much more than before. So we have a team of infection control nurses, and 2 will go out and spend the whole morning on the wards with the staff, talking about the patients, talking about bed placement for those patients, and they can see the live data coming through, so they're not missing anything as they're going around the wards, seeing those staff. But it's also that ability to talk to the doctors about their patients with the documentation from the microbiologists as well. They're using it readily and frequently. And it has given us time pre-COVID to focus on clinical issues. So looking at the training of staff, looking at support with, I was hearing a conversation about MRSA and MSSA earlier. We're looking at how we can reduce those healthcare acquired infections that we know and love and we miss, and working with staff to embed practice against policy. We really worked closely with our clinical site team, making sure that patients are in the right place. So we developed the isolation tool. Some of you may have access to that now. And that pulls all the PAS data, so the patient accessible data, into one place so we know where all our patients are who are in isolation. And then we can RAG rate that information. You can't do it, I see a nod. So we can RAG rate the patients. We have to manually RAG rate them. We can define what cleaning needs to happen for that room, and we define why that patient's in the room. And that is a live document that the clinical site teams can use, and if they're out of hours trying to keep patient flow going, they know which patients can come out of isolation at any given time. And as I said, it's ensuring that is live. And it's really helpful, particularly as we're moving into a different phase of the pandemic, that we can trust the site managers, we can let go a little bit of that part of our workload. And something we found with ICNET, it's provided us with a tool for training. So the structure of the processes within ICNET, for example, we're getting the lab feed, so we're getting that information from the lab. And as that comes through, we've been training our staff on what to do with each organism. We can set tasks within each organism and set some forms within ICNET so staff know what information they need to gather when they go to the wards. And at Dorset County, we have seen low rates of healthcare-acquired infections. Part of that, I believe, is because the ward staff and the infection control teams work really closely together. So there's these discussions when the infection control team's on the wards in the mornings, and at times they're joining the doctor ward rounds, getting part of that team to help support them, particularly in surgery, to reduce surgical site infections. So there's that discussions directly with the clinicians. And our rates have remained low, and we are working really well with that, those teams in maintaining that. I think visibility of infection control nurses is really important. When I first started infection control 12 years ago, it was like, infection control nurse comes on the ward, what's wrong? And a very, the arms go folded, and, it's a very difficult relationship to break down. But because we are visually there every day, they've got used to us. So we feel more part of their teams than ever before, to the extent that all of my team, they work on different wards on the bank. So they have that relationship. They feel, I'm going to work on that ward when I've got my day off. So there's a little bit more flexibility within my team to keep their clinical skills up as well, which is really nice to know. Prior to COVID, we did have minimal outbreaks. Even with norovirus, we kept those outbreaks pretty low. And, when you walk on a ward, you know when something's wrong. I mean, particularly with norovirus, it's very easy to detect. just from the smell, but we could work with the ward staff quickly to get those patients either in isolation or shut a bay down. Prior to COVID, we worked with the principal to shut a whole ward, even if a small area is affected, and then bring that ward back online quickly, because we've spent that time, 72 hours, we've excluded that area, we can get the ward open swiftly. But as I said, we didn't have particularly many beds closed with outbreaks prior to COVID. And we also felt there was a multidisciplinary team approach to infection control. So we were trying to make it everyone's business, infection control, which isn't easy. It really isn't easy. But the constant engagement with Trust Board, we had effective reports delivered from ICNET by having it set up as a routine information. If the Trust Board wanted that information about particular MSSA rates or MSSA rates, we could provide that information readily to Trust Board. And we've expanded our use trust-wide. So we, as you can see from that chart, we do have many staff using ICNET. We ask them to feed back to us their experience of using it so we can adapt it, adapt codes, adapt data to suit them. Particularly an interesting group to get involved were our surgical team. It was like, what's in it for us? What can we get out of this? We worked with ICNET and developed the surgical site surveillance module. So we do all our surgical site surveillance via ICNET. It's managed by a band 4 admin members of the team. Obviously, if we have infections, then the clinicians get involved and the IPC nurses get involved. But it's a completely computerized digital program with a few buttons being pressed, and we obviously do our sense checking of the data, and it's not manually uploaded to the Public Health England site, it's uploaded just through a CSV transfer. So we don't have to go individually into our Public Health Insight site and upload that information. And we have to do that on a quarterly basis, if not more, every trust has to do that. So it's quite time consuming if you don't have those things in place. We've also got live data extraction for SITREP purposes, so we can get that information readily, and particularly with our clinical site managers and our trauma coordinators, they're requiring that information as part of their reporting up to NHSEI, our sort of our governing bodies, requiring information usually on a daily basis. And something we've really promoted is the peer auditing process within ICNET. So we've set up hand hygiene audits and PPE audits in ICNET, which we encourage staff to action as well as the infection control team. So we've put the 5 moments in there, and we ask the matrons to peer audit other wards, and it has an area where we can self-populate if we're naming and shaming staff, which obviously we don't like to do, but sometimes it's required. So we can adapt it at any time should any of this team require it. And I do have to mention the COVID word. So the last 2.5 years have been like no other for all of us. And I think no one has been unaffected by the last 2.5 years, but I think for infection control nurses, it's been particularly tough times. We were turned to in 2020 and asked what we're going to do. And we knew as much as everyone else did, not a lot. But it's been a really tricky time. It's something we found by having ICNET was we had a consistent process in place which helped us through. We had members of our team shielding. So our key senior admin was shielding at home. So we thought we'd lost that functionality, but she was able to work from home with ICNET and carry out doing her workload. And we had 2 members of the team who were restricted shielding in the office, so they were able to carry on some of the general IPC actions as required. And as you know, at the beginning of COVID in 2020, hospitals were very different in the UK, and I'm not sure what the similar thing happened up here, but we actually had a lot of discharges to get ready for this wave of COVID coming in. And so the IPC was focused on COVID. So actually, by having my shielding staff doing the normal bits of work. It enabled my team to be out there doing the fit mask testing, the reassurance and that support out on the wards. It is 24/7 available, as those of you who use it know, and to possibly our detriment during the pandemic, it meant that we could keep an eye on things when we needed to. If you had that awful thought in the middle of the night, we'd log on and double check to see what was coming through. But it has that facility to provide that joined up thinking. The troubles we had with our frequent national guidance changes, I don't know about you guys, but every Friday night, at 8 o'clock on a Friday night, the government decided to put our national IPC guidance on, and I'd read it with trepidation, think, what do we have to change? One of the big things we had to keep changing related to PCR testing, which I'll go on to the next slide. But I think our resilience has been really tested over the last 2.5 years. But something we felt was actually ICNET was a member of our team during that time, because we knew that we could rely on it going forward. So we worked with our digital teams closely to make sure our results were credible. Those of you know, the platforms for testing for PCR were changing on regular timings. We started off receiving the results from Bristol to start off with, and it went to Porton Down, then it went back up to Birmingham, and then back to Porton Down, and then we started doing in-house testing. But each different route of testing meant we had to change the codings going through ICNET. So that was a little bit complicated, but the team were great and helped us go through that process, so we had no sort of time lost. We were able to maintain our ward rounds throughout the pandemic. I say that with caution. There was 1 week I pulled my infection control nurses away from it because I recognised that they were finding it tough. And I think, there was points where we all found it a little tough to be out there and people were scared and the infection control teams were having to support that fear. But there was a point where we pulled back and gave them that support. It enabled that data collection. So in our incident management team, they were asking for the information, how many cases have we had, how many cases have died, all that information. We created reports, so we had that data readily available. And I think it's really important to note that we could manage the other organisms alongside it. It was a bit of a bun fight. So if we had an ESBL, everyone got excited and wanted to look after the ESBL case. And the C. diff was a shining light when we had that in comparison to all the COVID. But it meant that we could concentrate on those alongside the COVID. We didn't need to forget about those. We could also carry on doing our surgical site surveillance at the same time because that was being enabled by our shielding member of staff. And it just became familiar in that unfamiliar world which we all experienced. So just in summary for that section, just to explain that remote working was really crucial. So we have all our microbiologists use ICNET, and so they have accessed it from their homes and they've been on call as well. So they've been able to have that information at the touch of a button, as it were. Our clinical site teams have had a really tough time as well, managing patients going to the right place at the right time. And with accessing ICNET, they've been able to see live, if we're not in the building, if we're not on duty, they can see that consistency going through. And they're all using it. So you go into our site office, we've got the A&E screen, we've got the bed management screen, and they've got ICNET up as well. So it's really helped to see that's integrated into the way they work. We've had minimal outbreaks during COVID, and they say minimal. We had our first outbreak in December 21, and that was a short-lived, smaller outbreak that led to, I think all of us had that experience in January 21, December 20, January 21, when we had that large wave of COVID. But we were able to really use the outbreak tools in that and test the outbreak tool and start helping with that prediction for when that outbreak may be over. We had to adjust it on occasions when we had further cases, but we were able to give that prediction to board. Our on-call teams and managers accessed ICNET as well during the period of time. They were getting challenged to provide information via business intelligence on daily SITREP data, which we had to feed into Public Health England and the NHSE teams, which similarly to what you would have had to do in Scotland. But that was a daily thing, so there was no days off for infection control, but actually having the on-call teams trained up to do it, they were able to do it for us on occasions. And I think something we've found really helpful is our contact tracing part of ICNET. So if we had a patient who was COVID positive, we could look back for periods of time to see how many patients they're in contact with and go through the process of isolating them. Although now we don't need to isolate them. I don't know if it's the same in Scotland. Has that changed your contact tracing? No. No. Well, we now in the UK, we don't have to isolate our contacts, whereas 4 weeks ago we did. So things change, but we're still able to do that, which is reassuring to us. So I just want to share with you, change tactics away from COVID, because I think you've probably had enough of COVID so far, is to talk about how we're moving forward with our integrated care system. So this is equivalent and similar to the way you manage your boards up here in Scotland. So all of the UK is moving forward with the way the structure of healthcare works. And the integrated care system has been talked about and plans have been put in place over the last 2 years. And from July this year, it will be formally in place. The board who manages this will be formally in place and will be managing as a system. So for Dorset, the stars in red are our acute trusts. So we have Poole and Bournemouth, which are combined, and they're called University Hospitals Dorset, ourselves in the west, and all the little blue stars are our community hospitals. So Bournemouth and Poole combined are nearly 2,000 beds, so they're quite a large bulk of beds. And each of the community hospitals can be up to 30 beds. So the communities can evolve as possibly a same number of beds as an acute trust. We've always worked closely in our infection control with our colleagues across the county, and we've had an infection control forum sharing policies. We meet to discuss C. diff cases, for example, put them through the PIR risk process. So we've always had that engagement as a team. But something we wanted to look at for many years is how we can actually move forward as a team with infection control. Looking at all the different systems within the ICS, we've had different PAS systems, different lab reporting systems. All of us have had different ICNET systems. So Poole had the older version of ICNET. We'd had the version 7 and onwards the NG's ICNET. Dorset Healthcare secured the funding for ICNET, and they were due to go live in January 2019. And Bournemouth had an Excel sheet. So very, very different way of managing. And we just felt there was a challenge because we were blind in infection control of how we could support each other as teams going forward. And recognising within the digital platform, it is a legal requirement that we have that information to hand. And they had other drivers for change. We found that we were experiencing more outbreaks between hospitals, particularly discharging from acute hospitals to community hospitals with potentially infectious patients. Turned out to be infectious patients and then causing an outbreak in a community hospital. We were unable to track patients across Dorset. So within the ICS model of care, we were starting to move specialties across Dorset. So Bournemouth covers all the vascular services, which means that we have some vascular patients at Dorchester, but we need to transfer them to Bournemouth for their major treatment. There was no tracking system. Our renal patients across the whole of Dorset, we were reliant on a nearly defunct renal system, so we didn't have that information to hand either. So how did we move forward? We wanted to have a single instance ICNET, so we wanted all to be singing from the same hymn sheet for infection control. We had several years of campaigning, and actually it's nearly 7 years of campaigning. So 7 years ago, we first put forward the idea that actually shouldn't we have our infection control joined up across the whole system. And the key was actually going into the ICS. It gave us that platform to push forward. So we took the proposal to the very newly developed quality group for the ICS and sold it in a way that they couldn't say no. But also quite by chance, at the same time, the One Dorset pathology group was setting up a one limb system. So their lab system was joining to be one limb system across the whole of Dorset. So it was an opportunity for us to piggyback on that development to get ICS across the whole of Dorset. So luckily within that, it meant that we had a transformation lead. So we didn't have to do all the hard work, which comes into developing a larger project. But it really took on the whole health economy approach. So the progress to date. So we established the clinical and digital forums to work through. And this was all pre-pandemic. So this was all possibly going through 2019. We're really ready to go. I'm looking at Val. We were ready to actually sign up and get everything sorted. We agreed that Dorset Healthcare, which is all those community hospitals, that would become the host, because they are taking patients from all of us. And at that time, they were using our data and UHD's data. So it seemed sensible that they would be the host instance. We went live with the host server in January 21. We'd already been using it for several years, so we just transferred over the data and we were ready to go. And Bournemouth and Poole went live in July 21. And actually, it was quite a simple transition. We worked very closely with the infection control teams over there, and they were very keen to get moving with using ICNET. Then the LIMS system was put in place, and then we had a few issues with the LIMS system. It wasn't ICNET. The LIMS system was such a large project, it was very difficult for them to implement all the data changes. So we are now in a process of going live for Dorset Healthcare this summer. So we're at that process of final finger on the button, here we go as a big system. And we're working with the Dorset Healthcare teams. They're a little nervous because they never had that opportunity to see everything, see all their hospitals in one place. So it's an exciting time for them. We're trying to, we can't imagine how it is if they can't see the information in different hospitals, and they're going to see it all in one place. But lots of lessons learned as you go through that process. We can never underestimate how differently we work in IPC. Just a simple thing like a tag we put on a patient to say they've got C. diff is managed differently in 3 organisations. And trying to get that agreement and that compromise that we're all doing the same thing. You know, I think the PAS alert for C. diff is the hardest thing to get that agreement on. Some trusts keep it on forever. Some trusts take it away from 2 years. It's very different how people's approach. We'd recommend that every organisation needs a few super users. So every organisation should have somebody who can write the reports, can flip the reports for you if you need them, and having the confidence of playing with the data for you. And we're really fortunate we do have a super user in our trust, but she's being spread thin across the whole county at the moment to help support them. I think engaging with digital teams early on, and I think that's one of the big lessons learnt with the LIMS project. Although from how we've all worked with ICNET and how the infection control nurses have worked, getting that engagement from the LIMS team has been quite difficult. And so it's not only affected us, it's affected the ICE system, those you might use ICE, some of the GP systems, all of the systems that link in with the lab system have been affected. But we're over that now, so it's really helpful. So as I said, next steps will be live this summer. We'll be testing the system and testing it to its maximum capacity. Bournemouth and Poole will be expanding their trust-wide use, so they'll be encouraging their site managers to use ICNET, and we have some of our team going over to work with their team to show them how it's done, and vice versa. And we're moving forward with I put clinical commissioning group, but they will become the ICS. They're going to be gaining access to the single system when it's ready, so they can work with GPs, particularly on things like C. diff and those sort of things, to work more of a system approach to managing some of these difficult to manage organisms, and particularly our gram-negative bloodstream infections. We're looking back at how we can manage more things in the community before they become acute and require further treatment in the hospital. So in conclusion, we've been provided with the tool to give us resilience for infection control. It's worked effectively through the pandemic and across the ICS as we're building that in. We have confidence with business continuity with ICNET. We haven't had any issues at all. It's something which we're really pleased that we have that trust in the system. We're looking at that blend of digital working with staff engagement. And I think part of that's because we've got that relationship with clinical staff. We have a different relationship now with them than maybe 15 years ago. And that's demonstrated from ward to board. So our quality teams and our trust board members are very well cited in infection control matters, even outside of COVID. So they feel that they have that evidence at the click of a button. And I think it's really important to share good practice about ICNET, but also look at the areas for improvement. And I think part of it is that understanding there's so much more the tool can give you, and we're probably at just the tip of the iceberg as well.